use that to communicate with Shelley Wiggins during the webinar. She'll answer as many questions as she can on the fly. We'll also address those when we get finished. We will record a copy of the webinar, so if there's anybody who would like that afterwards or who would need to share this with some of their colleagues, just let us know and we'll get you a link to the recorded webinar as well. Again, my name is Matthew Menendez with White Plume. We appreciate you spending some time with us this morning. We're going to move quickly through this material today, so I hope that it will be helpful for you, and hopefully we'll leave plenty of time for questions and answers at the end. Just real quickly, what we want to accomplish today, give you our goals for the webinar. The first thing we're going to do is give you some general background information on ICD-10. I'm sure many of you are well versed. We're going to take a bit of a different approach, tailoring this specifically for the ambulatory side of the house. So we're not talking about inpatient world today. We're really talking about physician practices and what makes ICD-10 difficult. There are some things that Medicare has done here in the United States with the implementation of ICD-10 that make it more difficult than a lot of the other countries who have done ICD-10 before. Some of the things that make ICD-10 even more difficult are the infographics, the marketing, the blog posts about ICD-10 use scare tactics, and I think that overwhelms some people and prevents them from taking steps to be proactive. Okay, so we're gonna look at that, try to dispel some of those myths, and then there are a lot of practices that are underprepared or that make mistakes. I'm going to share some of those with you today, just so that you can understand, and hopefully if that can prevent you from making a similar mistake, that may be helpful for some of the people today. Then we're going to really want to give you some tools to understand the impact on your particular practice. Okay, because that's where we want to focus. What are the impacts to your providers? What are the impacts to your revenue cycle? And how do you mitigate some of those risks? That's where we're going to focus, because those are the two biggest risks. We have to protect our doctors' time, and we have to make sure that you continue to get paid without having to hire a bunch of additional staff. And another theme that you'll see throughout our time today is comparing ICD-10 compliance with ICD-10 productivity. A lot of people think of ICD-10 as a pass-fail test, right? It's not pass-fail. There will be some people who do very, very well and have optimized their workflow and protect their providers' time, and there will be others who, yes, they can send out claims with ICD-10 codes on them, but they have not optimized their workflow, and that's going to make a key difference in how successful practices are in their transition to ICD-10. I'll certainly leave time for questions and answers at the end, so go ahead and send those in to Shelley, and we'll gather those and try to answer as many as we can when we get finished. So first off, what makes ICD-10 difficult here in the United States? Why is it different than a lot of the other countries that have already moved to ICD-10? Well, the first thing is it's a one-day conversion, right? That makes it hard. There's no transition period. There's no grace period. So the current law states that the conversion date is Thursday, October 1st, right? That means on Wednesday, any encounters of the date of service Wednesday, September 30th, have to be coded in ICD-9, at least for your claims. Everything with October 1st and later has to be ICD-10. Now, this is also not our first ICD-10 conversion date, right? I'm sure everybody knows ICD-10 has been delayed 3 times, twice by Medicare, most recently last spring by Congress. That makes it very difficult for people to prepare. The uncertainty from the government makes that difficult. And you have a lot of people who are kind of taking a wait-and-see approach. And the harmful thing about that is it shortens their runway. It also shortens the availability of vendors to be able to help them, because everybody's going to have a backlog working through upgrades, installations with customers, right? So it's like the boy who cried wolf. The government has cried wolf on this date many, many times. But remember, at the end of that story, the person who ends up hurt is not the boy who cries wolf, but it's the sheep, and ultimately the owners of those sheep. It's the physicians. It's the owners of those practices that will be hurt if they're unprepared. Other impact that's different here in the United States than it is in other countries is the change to physicians. And yes, ICD-10 was a change to physicians in other countries as well, but they're basically government employees, not small business owners like they are in the United States. And so our physicians in a fee-for-service world, they cannot slow down. They can't see fewer patients as a result of ICD-10. And they don't want to either. That's what they're good at. That's what they're trained in. That's what they need to be doing. And that's going to be a challenge. How do we make sure we protect their productivity as they use ICD-10, but also in their time to prepare? Most physicians would say, I did not go to medical school to be a coder, right? How do we get them ready for ICD-10 when they don't have the interest or desire or capacity to spend time in advance to learn about the new code set? That's a challenge for administrators, for billing managers, for whoever has responsibility for ICD-10 in your organization, of providing physician training. So we're going to talk about some strategies to do that, some things that you can do to help the physicians learn as they go. Okay? The last piece that I think makes ICD-10 most difficult is that 100% of cash flow is at risk. Right? All HIPAA-covered entities are required to move to ICD-10. So this is not just Medicare, Medicaid. It's all of your payers. And it's not an incentive program like PQRS or e-prescribing or even meaningful use. Right? It is all penalty overnight. So the stakes are very, very high for practices. And it's not just about getting claims out the door. You have to make sure you've got the right code the first time if you want your revenue cycle to function efficiently. That's the goal. But it's going to be difficult. Now, I've talked about what the government has done that makes that difficult for us. Let's look at some of the scare tactics that are really half-truths that make it appear more difficult than it actually is. One of the things that I'm sure everybody has seen is about the volume of the code set, right? 16,000 codes in ICD-9, 69,000 codes in ICD-10. That's true. That is true, but nobody uses all those codes in ICD-9, nor will you use those codes in ICD-10. For most practices, for most physicians, they use approximately 2% of the code set. So we encourage clients to examine the codes that they use most frequently. Let's see how those convert to ICD-10, and then what steps do you need to prepare. If you haven't done that, that's a valuable first step. But this is a distraction for a lot of people. They think about, oh my gosh, the number of codes is huge. No, you're not going to use all of those. Another distraction that I see in a lot of places, a lot of the non-healthcare media pick up on this when they talk about ICD-10 are some of the crazy, ridiculous codes, right? This is a favorite of everybody's, the flaming water skis, right? Now, what most people don't know is that a very similar code exists in ICD-9, and you never use it, right? You never use it in ICD-9, and you won't use it in ICD-10. It's a distraction for most people. It's a distraction for most people. Same thing, with the, unspecified spacecraft accident. Again, code exists in ICD-9, code exists in ICD-10. You won't use it in either case. Most of these crazy codes, if you'll notice, in ICD-9 they start with an E. They are E codes in ICD-9, external cause codes in ICD-9 and ICD-10. CMS has already come out and said if you do not use those E codes today, you will not need to use those in ICD-10. Right? So again, we don't have to worry about that. And I think they serve as a distraction away from some of the dangerous codes that are used today that will have negative unintended consequences in ICD-10. And I'm talking about unspecified codes. There are lots of unspecified codes, again, in ICD-10, and those exist in ICD-9 too. They can be very, very vague. But for the most part, in the ambulatory world, those unspecified codes are payable diagnoses. The claim will get paid. And the concern is, as we transition to ICD-10 in the short term, those codes may not get paid correctly by your payers, right? Some of the early end-to-end testing results have shown that those unspecified codes are getting denied. And that makes sense. The reason the payers want to move to ICD-10 is for the more specific, for the more granular data. If you send an unspecified code, they may deny that claim. They may underpay that claim. And then if you look a bit further forward into the future, long term, as we transition away from fee-for-service towards pay-for-performance, you're going to need the rich data available in more specific ICD-10 codes if you want to maximize your reimbursement. It's a good practice to, as we make that transition to ICD-10, try to leave the habit behind of using those unspecified codes. And I'll show you some examples of that to hopefully bring that point home to make that a bit more concrete. But I do want to make that point that don't worry about some of those crazy codes that you never use. Let's look at the codes that you do use most frequently and see what those look like in an ICD-10 environment. And we're going to get to that very, very soon, but I did want to share with you some of the mistakes we see practices make, just a couple of them real quick. And again, they're good ideas, but they're not complete ideas. A lot of practices focus on ICD-10 as a coding project. I'm getting my coder certified, getting my billing people trained on ICD-10, but that's really it. Those are the people who are going to be impacted by it. Everybody else is going to be okay. Again, partially true. Yes, it's a huge change for certified coders. You know, the biggest change since ICD-9 was introduced 30 years ago. But that's only a part of a good ICD-10 strategy. A lot of people also make the mistake of it's really an IT upgrade. You know, we've got to upgrade our systems, you know, check with our clearinghouse, check with our PM, check with our EHR vendor, make sure we're on the right version, and all of those are very good things to do. But that's just aiming at ICD-10 compliance, not ICD-10 productivity. You have to understand the workflow, right? What's going to happen? How is that going to happen? How many clicks is that going to take? Will my doctors be able to do that? You have to view ICD-10 as a strategic initiative because of what's at stake here. And again, that's what we try to get people to focus on, is protecting against a decrease in physician productivity, protecting against a decrease in revenue cycle efficiency. And when I'm talking about revenue cycle efficiency, what I mean is the cash flow that you're able to collect with your current FTEs. If your cash flow goes down or your FTEs go up, neither of those are good outcomes from a revenue cycle perspective, particularly for something like ICD-10 that's an unfunded mandate. Just to share a couple of data points with you real quick, this is a study that came from the advisory board. They looked at what impacts were felt in Canada when they transitioned to ICD-10. And if you look what they put front and center, it's physician productivity. An expected decrease in physician productivity of 10 to 20% is entirely unacceptable here in the United States for most practices. We can't expect physicians to spend less time with their patients or less time with their families. Let me get underneath that number a little bit and tell you what was happening. Basically, coders, billers were going behind trying to code the encounter for the physician, and doctors were spending 45 to 90 minutes per doctor per day answering follow-up questions from coders. And again, that is unacceptable. We cannot have that. Even if you cut that number in half and say it's 20 to 45 minutes, that's unacceptable, particularly here in a fee-for-service world where doctors are paid on their productivity. That's not how they want to spend their time. That's not how they need to spend their time. Now, yes, I'll talk about the other two components of this, but I think that is far and away the most important point here. Because, yes, coder and biller productivity will decrease, particularly in the first 12 months. You see that 20 to 50% decrease in their productivity. They will regain some of that long term, but they'll probably never get back to ICD-9, current productivity levels. And then you look on the far right hand of this screen, you see a rework productivity declining 10 to 25%. That's because of an expected increase in denials. CMS has said they expect denials to double or triple in the short term as a result of ICD-10. That's been visible in the end-to-end testing that CMS has done so far this year. So if your CMS denials are at 2%, 3%, those could increase 4 to 9%, right? And we want to make sure that you prevent as much of that as possible. Certainly there are going to be problems that the payers have. There are going to be changes that the payers make. But we want to make sure that you're in the best position as possible to respond to those changes and prevent as many of those denials as possible. So we're going to start with talking about the physician productivity. We'll move to the revenue cycle piece. But I think the physician time is clearly what's most important. They're the only ones that can take care of our patients. They're the only ones that can generate revenue for the practice. Okay, so where do we begin? I mentioned looking at the codes that are most commonly used. We've done this for all of our clients just to share some data with you, looking across and looking at the codes that they use most frequently. It doesn't represent 100% of their encounters, but these codes probably represent for each specialty about 95% of the most commonly used codes. All right, we take that, we convert that into ICD-10 codes, and what you'll see is across the board a significant increase. The average increase is about 4.5 times the number of codes in ICD-9. You'll see orthopedics is obviously the outlier. They're the most difficult specialty to convert to ICD-10 by far. But we try to go a step further than that and categorize the codes and categorize the conversion. Some of those, the first bucket is a low-risk category, and that means there's one code in ICD-9, and it can be converted into one code in ICD-10. This is the easiest. I'll share some examples of those with you. But for most practices, it's somewhere between 15 to 40% of the codes used on a day-in, day-out basis fit into that low-risk bucket. Again, depending on the specialty and the specific codes that they use. Moderate risk codes, these are the ones where there's additional detail available in ICD-10. And there are between 2 and 10 choices in ICD-10 for each of these ICD-9 codes. Most practices, this is where the majority of their codes will fit. But everybody is going to have some of those high-risk codes. And those high-risk codes are ones that have 11 or more choices. There are some that have dozens or even hundreds of choices. And again, I'll share some examples of those with you as well. This is ICD-10 conversion analysis. It's actually a free service that we provide for anybody who attended one of our webinars. So if you would like that done, you feel free to, you get a follow-up email from me after the webinar is over. Feel free to let us know that you'd like that. We can do that for you. If you want to message or do a question to Shelly and let her know that you'd like that, we're happy to do it. It's a free service, and it's a good, helpful step. Let me show you what that looks like. If you send us an Excel file with your ICD-9 codes in it, and most people get that data, either a frequency report out of their billing system, or they just get the data off of a super bill. You typically have the most common diagnosis codes listed on it. We'll send you back a file that looks like this. It's got the summary data up at the top that you saw on the previous slide, but it also provides the line-by-line detail. Right? So you can see for a diagnosis like cough, that's one of those low-risk codes. Carpal tunnel is one of those moderate risk codes. Pain in an extremity, that's a high-risk code. So you'll get all of that data, and it's helpful to share with other people in your organization because it's not abstract, it's more concrete. It's sharing the actual data based on the actual codes that are used in your practice. And for a lot of providers, when they see this, it relieves a lot of the anxiety, a lot of the tightness in their chest about ICD-10 that says, okay, I see that, that's not that bad. I think we can do that. And that's a helpful first step. If you haven't done that already, again, free service we provide, happy to do that for you if it's helpful for you. Now, if you're a data person, if you're a visual person, this is a very, very helpful way to look at it. If you're more of a picture person, right, let me show it to you this way. I'll pick on the American Academy of Family Practice for a second because they have this on their website, right? It's a recommended super bill, charge ticket, fee slip, encounter form. You know, I've heard so many different terms for that same piece of paper. They recommend the usage of this. It looks like every super bill I've ever seen. CPT codes on the front, that's what you see on the left-hand side of your screen. Diagnosis codes on the back, that's what you see on the right-hand side of your screen. Okay? It's the fastest thing for the provider. They can typically fill it out in 7 seconds with their eyes closed because they know where the codes are on the page. It's also a very effective billing tool because it typically gets all of the billing data necessary to the provider, to the billing team, so that they can get the claim paid the first time. They don't have any of that back and forth asking doctors the follow-up questions that takes 45 to 90 minutes based on the advisory board study in Canada, right? So it's fast and easy for the provider. But what really caught my attention was they also had an ICD-10 version of this super bill. That's what I was interested in and wanted to take a look at. The CPT codes are the same. There's no change there, right? But the backside, that's what really was interesting, where they put the diagnosis codes. It was 8 pages long. You know, an 8-page super bill is no longer an effective tool for the provider, right? Most doctors just wouldn't do it. They're not going to flip through that, not to mention, you know, the workflow nightmares that would cause in an office. So what do I do? Can I make that a really small font? You know, yeah, that'd be an option, right? You can take that normal size font and shrink it down and put all those codes there, but that's not going to work for anybody. You know, kind of a funny joke to show, but it's not going to work for anybody. Nor could you ask people to use a jumbo super bill like this. You can fit all those codes on there as long as you make it, you know, 4 feet tall. So when you think about that, you say, okay, so what are my options? What can I do? You know, I've got this real estate problem. I can't fit 800, 1,200, 1,300, 6,000 codes on an 8.5 by 11-inch piece of paper. What am I going to do? Well, maybe I can have I can list the 200 most popular and then write in the next 1,000 codes. You know, doctors write in the description, somebody codes it downstream. The problem with that is the descriptions are different in ICD-10 as well. Most physicians write that in shorthand, not writing out a long description. And what that means is you go right back to the 20 to 45 to 90 minute per physician per day problem of coders and billers going back and asking the physician those questions, right? So to understand how to fix this problem, you have to understand what makes that piece of paper so popular for physicians today, and it's the doctor's muscle memory. They know where the codes are on the page. They can fill it out with their eyes closed. That's what makes it so easy for them. That's what makes it so popular. So what have we seen practices do? 3 different solutions that we've seen. I'll walk through each of them. You know, certified coders do it in an EHR or do it with an electronic super bill. Kind of the 3 main categories we've seen people, at least within our client base, what they've done. The first one is hire certified coders. This typically comes from, you know, somebody read a thought leader or a consultant or talked to the hospital, because the local hospitals are typically hiring certified coders as fast as they can because they can afford it. Most practices cannot, because coders are expensive employees, and they are getting more expensive, right? There are not enough of them. A lot of people are looking for them, so they're getting more expensive. If you're able to find one, you do need to make sure that they are certified, that they're trained, that they're ready to go, right? But also be prepared that they will be less productive in ICD-10 than they were in ICD-9. This model works well for expensive inpatient stays, expensive procedures, but for the day in, day out high clinical volume that most practices see, just from an economic perspective, it doesn't work particularly well. But it means no change for physicians. Another, second option that I've seen more practices do is we're going to mandate that all of our doctors capture all of that data through the EHR. You know, a lot of groups have some doctors up on the EHR, or others that are using it but aren't using it to capture all the charge data. typically, and they're using ICD-10 as kind of the stick to get everybody to do that. The problem there is not that our doctors are non-compliant or that our doctors are Luddites. They're worried about their productivity, their time, right? And you hear a lot of them that are counting clicks. I don't know if any of you have click counters in your office, but they're worried about the number of clicks. If you hear that complaint today and your plan is to get them to do that in their EHR and ICD-10, do not expect that complaint to go away. It's in fact going to get a little worse because ICD-10 is more difficult, number one. And number two, the methodology that most EHR vendors have chosen to implement ICD-10 is code search. It's the fastest to develop, it's the fastest to implement, but it's not the fastest to use. And here's the problem with code search. Google has ruined us. We all expect everything to work like Google. And when you search for something in Google and you get 9,000 results, 99% of the time, the answer that you're looking for is one of the first 3 results, right? That's not how it works in code search. If you search for a code and you get 30 or 200 search results, your doctor is going to have to redo all of those choices to choose the one that's most accurate. And if those are sorted in code order, as most of them are, the ones at the top of the list are unspecified codes. So if the doctor's trying to move through that quickly, there are probably going to be some unintended billing consequences downstream. That's why it's important to understand how your software vendors are helping you solve the ICD-10 problem. You're not looking for just a checkbox, a yes answer, yes, we're going to have ICD-10. You want to understand how that's going to work. Is that going to work for my providers? Is that going to work for my billing team? Right? If that's not going to work well for them, or if you have doctors that won't do that, or if you have doctors that, they're probably 25% of practices do not have an EHR. A third option there is an electronic superbill. We call it AcceleCapture, designed to protect physician productivity, designed to protect that muscle memory that they have, and at the same time, make sure you get the right code the first time to the billing team. So let me show you how that works. I'll show you a couple examples of those low-risk, moderate-risk, high-risk codes so that you can start to understand how that works, what that looks like. I'm going to do 2 encounters side by side here. And I'll do the first one in ICD-9, right? And then I'll turn around and do the exact same encounter in ICD-10. Okay? So watch. We'll start on the left-hand side. We'll do ICD-9. And I'll just choose some family practice-specific examples. This is an electronic superbill. It interfaces with almost every major PM/EHR systems that are out there. It's custom designed for each practice. Some practices have multiple superbills. In paper world, they'll have multiple superbills electronically. So when I'm ready to see this patient, and I have, maybe I've got a level 3 office visit, I've got a CBC, flip over to the back side, and I've got my diagnosis codes. Again, it should look just like my paper ticket. That cuts down on the training time required for your physician so they can learn how to use this very, very quickly. It also maximizes their productivity as they actually use it because they know where the codes are. So quickly, if I've got a patient that has cough and carpal tunnel syndrome and congestive heart failure, 1, 2, 3, make those clicks, make those taps. If I'm using a touch screen, and I'm done. Fast, easy, routes all the information to my billing team. Can actually post the charges to the practice management system to automate the charge entry function. Great in ICD-9. Let's look at that same encounter in ICD-10. We'll do it side by side so you can see the differences. The front side stays the same, right? No changes here. Everything's in the same place. Nothing has changed. And what I want you to think about is, think of me as one of your providers. It's Thursday morning, October 1st. I haven't come to any of the ICD-10 training classes. I'm just going to try to figure it out as I go. Let's see how I do, right? Front side, no change. So far, so good. Let's flip over to the back side. Remember, the back side looked like this, one page in ICD-9. Is it going to be 10 pages long in ICD-10? No. It looks exactly the same. That's the magic of what you can do here with an electronic super bill. Everything looks the same. All right, so far so good. Let's click on cough. Watch this. When I click on cough, that's one of those low-risk codes. It can be converted automatically into ICD-10. We love those. Providers love those. I wish everything were a low-risk code. If it were, a computer could handle everything ICD-10 for you. But it's not. For most practices, that's somewhere between 15 and 40% of the codes they use day in, day out. So let's look at something that's a bit more complicated, like carpal tunnel syndrome. When I click on carpal tunnel, you'll see it can't convert that for me automatically. So it gives me a pop-up. And you'll note that there are 3 choices here. There are 3 ICD-10 codes for carpal tunnel syndrome. Left arm, right arm. And then look at that third one, unspecified arm. That's the problem. That code exists in the code set. You can go look it up in the code book. Tell you what it is. If you hover over it, you'll see it's, what's that code? G56.00. Do you want your providers using that code? Probably not. If you had a face-to-face encounter with the patient, you should know which arm they were complaining about today. Payers are probably going to deny that, or even worse, they may underpay the claim. Most of our clients are choosing the configuration setting that says, yeah, there are a lot of unspecified codes, but I don't want to show, at least any of the unspecified laterality codes, don't show those in these pop-ups. We don't want to use them, don't even show them. And it's important to be able to make those types of decisions for your practice because coding is part art and part science. Reasonable people can disagree on that. So our clients can choose that on a client-by-client basis. So let's assume it's in the right arm. One extra click, it closes that for me automatically. I don't have anything else that I've got to do. I'm done. Easy. I can do that. All right, let's look at something, one of the high-risk examples, and I'll show you 2 of them as we go. Congestive heart failure. Right? When I click on this, you'll see that it shows me 15 choices. Right? I've got 15 choices here. And we don't list those in a big, long list because we don't want your doctors to have to read through all 15 like an SAT test and choose the one that's most accurate. We've organized this into 2 dimensions for them so that you have the onset on the vertical axis there, acute, chronic, acute on chronic. And you also have the type of heart failure on the horizontal axis. Is it systolic? Is it diastolic? Is it combined? So it lets them recognize the pattern. So again, only one extra click, no drilling down. They can say, I've got a patient with chronic systolic congestive heart failure, closes that for me automatically, and I'm done. Okay? As an aside, as a bonus, we do have some clients who have providers that are still dictating. They like to use their paper super bill as a reminder, you know, when they're going to dictate at the end of the day who they saw, what they did. They a lot of times have staff that print these out for them, or they can review them later. Summary tab shows them everything that's there. It's got the ICD-10 description in that for them. And what that means is it can serve as a reminder or an on-the-fly training tool of where they need to be more specific in their dictation. Right? Now, most of them are probably documenting the laterality for carpal tunnel syndrome already. Right? And they're probably, most of the time, documenting at a level that's specific enough for ICD-10. That's why it's helpful to look at that conversion analysis, because it soothes some of those fears. But this is a helpful tool as a reminder for them in the first couple of weeks or months as they're getting used to ICD-10 to make sure that they're documenting at the appropriate level. I told you I'd show you one more example of one of the high-risk codes that was on that conversion analysis, because you can use that conversion analysis as a tool to know what you're going to see in the pop-up. See, I've got pain in extremity. I've got 31 choices. When I click on that here, let me find it real quick. I've got I think it may be listed as limb pain on this one. The tricky part of super bills, everybody wants to do it a little bit differently. Here it is, pain in limb. When I click on that again, you'll see that pop-up is done in 2 dimensions where you've got the anatomical location on the vertical axis, laterality again on the horizontal. So if it's in the, the right thigh, 1 click closes that window for me automatically. Again, trying to make you a hero by making ICD-10 a non-event for your providers. Right? That's the goal, and that's why we wanted to go through those couple of options of how we've seen people handle it, because you do want to make sure that you think about your workflow, how that's going to look when October 1st arrives, so that you can plan in advance rather than responding to that in a crisis mode on the first week of October. Now, I've talked a lot about providers because I think that's the most important thing, but in our last couple of minutes here, let me talk a bit about the revenue cycle, right? And then I'll make sure I answer any questions that we have that are for the good of the group. It is a big change for providers, but it's also a big change for the billing team. And when you think about this from a very, very high level, when we're still working in a fee-for-service world, you get paid for CPT codes today. And you have to have a diagnosis code that makes it medically necessary. That's true in ICD-9. That's true in ICD-10. If only it were that easy, right? Because you still have to play that cat and mouse game with the insurers, right? That says, I've got to jump through all those hoops to make sure I get the claim paid correctly. And to add another layer of complexity to it, not all payers want that to look the same way. Blue Cross wants it one way, United wants it another way, Medicare wants it a third way. You probably have people in your office who know the ins and outs of the billing requirements from your payers in their head. And they keep up with those as changes come, as new policies come out, right? And the volume of change is relatively stable, from quarter to quarter. The problem with that is when we go to bed on September 30th and wake up on Thursday morning, all of that knowledge goes out the door. Right? The cat and mouse game will still exist, but the details of that game will be different. And again, all payers are not going to handle that the same way. But it's not just a one-day change for them, right? Think about what's going to happen on October 10th or 15th or 30th. Payers are they've never done ICD-10 before either. They're going to be making adjustments. They're going to be making changes to their adjudication process, and you're going to have to respond to those changes to keep up with that. And the volume of change, the rate of change, is going to be much higher than anything we have seen in our careers. So what we have to think about is, what does that mean for me? How am I going to manage that change? Who on my team is going to manage that change? What types of tools do they need? And maybe more critically, what happens if we don't do that, or if we don't do that well, right? So that's where we recommend, if you're going to run a marathon, if ICD-10 is going to be a marathon for your billing teams, you need to start getting in shape for that now. So what we recommend is putting in a process, and you can do this with lots of different tools. Our clients do this, but you don't have to be a White Plume client to put in a process like this that says, I'm never going to rid the world of denied claims. That's a reality. I'm going to have to deal with that. There will be changes. But what I can do is when I see a new denial, when I see a new policy, I'm going to go through this process, right? I'm going to go back to the beginning. I'm going to figure out what went wrong, right? And I'm going to figure out how to make sure that I don't have that same problem happen again, right? What our clients do is they build in a new rule, and what that means is the next time that exact same scenario occurs, whether it's in 2 hours or 2 weeks or 2 months, that rule is going to fire the same way for all of my employees, whether it's my most senior coder or whether it's my newest billing clerk. That lets me have everyone perform at a higher level. It makes it easier for them to keep up with the change. Okay? And then what that does is that makes me be able to prevent that denial the next time, right, so that it doesn't happen again. I'll show you just a quick view of what that looks like in our application, just so you can kind of get a quick feel for that, okay? What you'll see is, and this typically happens after the electronic superbill is completed, but before the charge is posted to the practice management system. It has all the charge data at the top of the screen. It has all of the errors, alerts at the bottom of the screen. This particular one is a Blue Cross Blue Shield patient who we have an ICD-10 code, that H61.20. If you look in the bottom left, is impacted cerumen, but it's unspecified as far as which ear we're talking about. So this error alerts the billing employee to know, I've got a problem here, I need to correct it. It gives them not only the problem, but the actionable information as far as what they should do to correct that, so that they don't have to go look up the new ICD-10 code, because they're going to be learning those as they go, right? They don't have to go look that up. They've got it right here. They do need to make sure that they check the documentation so that they can use the right code, but this makes sure the code is paid completely and correctly the first time, right? That will help my revenue cycle now, but also help me be prepared to handle that in ICD-10, right? And that's the difference between ICD-10 compliance and ICD-10 productivity, right? What do you want your office to look like in October, November, December of this year and into 2016, right? Is the goal just to be able to submit claims in ICD-10? Or is the goal to make sure that our workflow is optimized, that my provider's time is protected, right? Because I don't want them to have to be staying late to answer coding questions. I want to protect their productivity so that they can remain focused on their patients. We let them be doctors, not coders. Because if they're focused on their patients, our patients will be happy. And that's the goal at the end of the day, is to take care of our patients. What about the billing department, right? Do we want them working overtime? Or do we need to be able to provide them with the right code the first time and give them the tools that they need to keep up with the changes coming from the payers, right? Because we cannot hire additional billing employees to handle this, because again, ICD-10 is an unfunded mandate. There's no additional revenue associated with the ICD-10 change. There's no incentive money, right? It is supposed to be, from a budget perspective, revenue neutral to the government for CMS, right? That means if we cannot be as effective, as efficient as you are today, the practice will be less profitable. And that's my concern, is at the end of the year, many practices will be less profitable than they are today, and they won't really know why. They'll chalk it up to more government change, intervention, regulation that we've got to comply with, and that'll all be true, but it doesn't have to be that way. If you aim for productivity, if you take some of those steps to make sure that you're ready, you can actually be more profitable than you are today. If you can automate some of those processes, if you can put a good system in place to capture the right data the first time, to prevent denials in ICD-9 and prepare for ICD-10, that helps you be more profitable. So I hope that was helpful for you. I know we went through a lot of information. I know we've had some questions that have come in. I'm going to try to answer as many of those as I can. But please feel free to reach out if there's anything that we can do to help you. If there are any questions that you have, feel free to go ahead and reach out, and we'll help you. Our website, www.whiteplume.com, you can find our contact information.